Good afternoon. Okay, you had lunch, yeah. So it will be like digestive, it will be a review. It is not teaching, classical teaching. It's like review just to try to respond to this interesting question, why is ultrasound useful in hands of a surgeon? So how many of you operate? Okay, so I also saw someone here who didn't raise the hands, but they do operate. Okay, so by definition, surgeon is a medical practitioner qualified to practice surgery, and sonologist is a physician skilled in diagnostic, ultrasonography, and interpretation of the images. But surgery and ultrasound are not two independent worlds. I do believe, and we do believe, that there is a great synergy. So we have currently an emerging concept of surgeon sonologist that can be defined as a medical practitioner qualified to perform surgery, but also able to perform ultrasound. And currently, we do not have lots of surgeons, sonologists, but we do believe that that kind of specialist in our area can offer improved service to our patients. And within the International Society of Gynecological Endoscopy, and through the project that I'm coordinating, Sonomics project, with great enthusiasm, we try to increase the time and exposure of surgeons during the residency and after residency to ultrasound. And I thank you really, I would like to thank Canon for offering this kind of sessions and paying attention to this topic. So, supporting our concept of integrating ultrasounds in surgical training. Basically, I will identify broad principles on why ultrasound is an essential tool in preoperative phase. Then I give many examples. Next, I try to identify the possible benefits of ultrasound during surgery and in postoperative phase. And now let's start with the first sub-question. Why is ultrasound an essential tool in preoperative phase when we plan surgery? So this is a woman I saw 2 months ago. She was sent to me. She said, look, the lady came from another continent. She was operated and we didn't know what was left in the pelvis. And she was 20-year-old patient, and she's still nulliparous. And she was operated due to acute pelvic pain resistant to pharmacotherapy in settings with no minimally invasive surgery and in settings with no ultrasounds. And this is the only external result of the situation that was purely hemorrhage from a functional ovarian cyst. And I'm pretty sure that all of us know that this is the basic principle of a success in surgery. Right surgeon, right patient, and right surgery. And ultrasound is one of the cornerstones in determining the patients who are good candidates for the surgery. Also, it provides us with information to select the right surgery and select right route for the surgery, vaginal, abdominal, laparoscopic. And also, it's also important to define the surgical theme. Ultrasound in preoperative phase provides the diagnosis, describe the severity of the situation, and also may provide the information and the findings that we cannot see during the surgery. Or maybe we can see it lately, and we wouldn't like to be surprised during the surgery. And probably this is the most important, ultrasound sometimes, thanks God, can inhibit us to perform surgery that is not indicated. So, from the counseling, from the information important that we counsel appropriately the patient, to the organization of the surgical teams, and finally, that moment when we finish surgery and we come back to the patient, and when the patient is able to speak with us, the patient do not like to be surprised as well with unexpected information. So, examples. let's start with the myometrial pathology. Thanks to impressive work of the Musa group, we now have the terms, definitions, and methodology to describe myometrium and myometrial pathology. And of course, myomas are particularly frequent. We can treat them surgically by myomectomy or hysterectomy. There are different routes regarding myomectomy: hysteroscopic versus laparoscopic, with or without robot assistance, with or without morcellation, versus open laparotomy. And ultrasound, 2D, 3D, especially, and also contrast-enhanced ultrasound will provide us with the number of the lesions, with the size of the lesions, individual size, and precise localization. And when we plan hysterectomy, then ultrasound provides the information on the uterine volume, then shape. Sometimes I think it's much more important. You know, it's different to operate a woman having subserosal myoma in close contact with ureter or over uterine artery, for example. And then we also can use ultrasound to understand the motility of the uterus and understand if there are other comorbidities, including adnexal pathology, adhesions, etc. So just quickly, I would like to say that ultrasound may provide us with atypical findings. So we should think eventually including some other strategies to understand the risk of sarcomas, although there is no pathognomonic finding using ultrasound or MRI, or even intraoperative. There are no pathognomonic intraoperative findings for sarcomas. Regarding the hysteroscopic myomectomy, we use frequently contrast-enhanced ultrasound and step W classification that is not validated, but we think at the moment is the best that we have to predict the risks during the surgery and to predict the complexity of the hysteroscopic myomectomy. And what about the adenomyosis, also frequent myometrial pathology? Thanks to the Musa group, we have direct features, we have pathognomonic features, diagnostic features of adenomyosis, and also indirect features. And it's important to differentiate myomas from adenomyomas, simply because adenomyomectomy is much more challenging comparing to myomectomy, and also the good diagnosis of adenomyosis. It's important not to decide the surgery, to select, for example, pharmacological treatment, or to select invasive treatment, adenomyomectomy or hysterectomy. And let's now speak a bit about cavity and endometrial pathology. Here we have also impressive work of IETA group. We have here, as you can see, the system of terms, definitions, and measurements for endometrium, endometrial pathology, intracavitary pathology. IETA provides also the description of the intracavitary typical findings of, for different intracavitary lesions in both symptomatic and asymptomatic women, and also in both pre- and postmenopausal women. And even something that is more important here, at your right side, you can see the reassuring findings in women with abnormal uterine bleeding. And also now we have a good ultrasound-based algorithm for preoperative phase, how to triage the women with abnormal uterine bleeding. In the case of atrophy, what is appropriate to do? Nothing, send a woman back home. In case of diffuse lesion, as hyperplasia and cancer, it's appropriate to perform sampling. While in the case of focal lesion, like polyp of myoma, it's appropriate to perform hysteroscopy and resection. So currently we have ultrasound-based algorithm for women with abnormal uterine bleeding based. So once again, it's an ultrasound-based algorithm. So in the case of teen regular endometrium, we do not need to proceed with the investigation, or we should try to identify the cause outside uterine cavity. Then focal lesions, hysteroscopy, resectoscopy, and then diffuse lesion, we can sample the lesion, try to sample if we have enough tissue, okay. If we do not have enough tissue for the diagnosis, then go in the second phase to perform diagnostic hysteroscopy. And still speaking about intracavitary pathology, adhesions, very interesting topic. Ultrasound, contrast enhanced ultrasound is fundamental to understand the degree of the lesions. And also, when we speak about the malformations, including of course the malformations of cavity and all other uterine and extrauterine malformations, if you asked me 20 years ago, I would speak about laparoscopy, MRI. Today I think that there is no doubt the gold standard is a 3D ultrasound, or even contrast enhanced 3D. And what about the Adnexa? Here I think that also we do not have lots of doubts that ultrasound is fundamental in preoperative phase. The first, how in 2024, what is the answer to this question? How to understand whether the lesion is benign or malignant? What would you say? Simple rules? Benign descriptors? Adnex? ORADS? Risk of malignancy index? Okay. Based on IOTA studies, okay, the response is two-step strategy using benign descriptors in the first phase, and then the Adnex model, and how to categorize the risk and manage the patient using the risks predicted by Adnex model or ORADS lexicon. So what we used to do in the first phase, when you observe a lesion, we try to apply one of four descriptors. Benign modified descriptors. If they were applicable, then the lesion is considered benign with the risk of malignancy less than 1%. If we cannot apply them, then we go to the second step and use the Adnex model. And then, based on the Adnex model or on using ORADS system, we can categorize the patient and provide appropriate treatment. For example, if in most centers, if the risk is less than 10%, it's appropriate to offer treatment or follow up by general gynecology. Otherwise, risk 10 or more than 10%, then we will refer the patient to an oncological unit or oncology center. And that's my favorite part, endometriosis. I think it's fundamental to map appropriately an endometriosis. Here you can see laparoscopic and ultrasound images of three most frequent phenotypes. So we can here see superficial endometriosis, we can see an endometrioma, representing ovarian endometriosis, and we can see nice Canon image of a deep lesion of the bowel. So deep lesions, deep endometriosis. Really, both ultrasound and MRI, they are very useful tools in experienced hands. And to reduce that huge interval of time between the onset of the symptoms and the treatment, we do not consider laparoscopy, diagnostic laparoscopy, as a gold standard anymore. And it should be only performed in patients with negative imaging results, or when the empirical treatment is not appropriate or is not, it does not work. So, using the transvaginal ultrasound and IDEA approach, you can see we really have good accuracy, sensitivity, and specificity for ovarian lesions and also for deep lesions as well. But what you can see here, that the sensitivity and specificity depends and varies between the different structures. For example, we are very good for the bowel, but for the uterosacral lesions, and those are the most frequent lesions in posterior compartment, we have quite low sensitivity, but very good specificity. And I do believe that we have to train how to identify it. Because of that, you organize the courses, you know, with one of those machines, you know, how to identify. It's so easy to touch, to pulp, but also to characterize using the transvaginal probe, the uterosacral ligaments and other structures, but the training, of course, is fundamental. So for endometriosis, we follow the IDEA methodology. Here are the famous 4 steps. The order is not mandatory. The first one is the assessment of the uterus next, a classical ultrasound. And the second, we assess indirect signs, soft markers, site-specific tenderness, and ovarian mobility. And this is the great advantage of transvaginal ultrasound. This is a dynamic technique, so please try not only to describe and measure, try to see if the structures are painful and how they move. So this is the second step. And in the third step, we use real-time ultrasound-based sliding sign to assess the pouch of Douglas, the status of pouch of Douglas that can be obliterated or not obliterated. And if it's obliterated, it can be completely obliterated or partially, left or right side. And then mapping the lesions in anterior and posterior compartment. We organize many courses, thanks to the Canon in November. Also, it will be some webinars. It's good to believe in someone describing the lesion, but when a surgeon sees the lesion, I think it's completely different, you know. So in the anterior compartment, we assess uterovesical space, we assess ureters, bladder, and of course assess the kidneys for hydronephrosis. And when we assess, we do not only measure the lesion, we have to try to understand is it painful or not, because we treat clinically relevant. If we decide for the treatment, it has to be clinically relevant approach. And also, when we see the lesion, we have to provide and to understand the feature, surgically relevant characteristics. I'll give just a quick example. For example, if you observe that that bladder nodule, we have to understand if it's exactly localization, its relation to the ureters. Is it penetrating to urothelium, or it's only located within the detrusor muscle, you know? What about the relation with other structures, etc.? Okay, and in the posterior compartment, okay, we divide that and evaluate didactically three subcompartments. So vertical one, this is rectovaginal space, fornix, retrocervical space, and Douglas. Then we have the second, the lateral one, including the uterosacral ligaments, peric side wall, and finally the rectum. Okay. So I think we all use ultrasound already in pregnancy-related complications in the first trimester, miscarriage, ectopic pregnancy, molar pregnancy. You can see how it's important using ultrasound to recognize the, what is it? Is it the cancer? What is it? It's enhanced myometrial vascularity, a normal physiological response to retained product of conception. And on the other side, you can see interstitial pregnancy. Also, ultrasound, I'm speaking a lot. Yeah, how many minutes do I have more? Few. Okay, that we also discussed. You can see here the niche. It's fundamental to assess also the niche and to characterize the complications of the niche, because niche on its own, it's not relevant. It's relevant when associated with the symptoms. Okay, and what are the possible benefits of intraoperative ultrasound? So from preoperative, now we are passing to intraoperative phase. You know, in different other settings, ultrasound is used much more than in gynecology. In gynecology, we use for minor procedures like ovocyte collection, aspiration of abscess, of hematoma, ovarian cysts, of course, to monitor the treatment of miscarriage. But when we come to really complex gynecological procedures, ultrasound, intraoperative ultrasound ultrasound is in its infancy. And it can be useful, but we have to have a good quality equipment and a surgeon who operates. And you can see I was not very satisfied with that apparatus that I had in this setting, but I thought, okay, it's better to give me anyone if you cannot give me a good one. Okay, so it can be useful very briefly in laparoscopy. Real-time guiding, imaging-based, ultrasound-based guiding can be very important when we should remove a lesion and be minimally radical to the normal surrounding tissues. And where it's important when you have borderline tumors, namely the recurrence of borderline, like this one, or where we have a small cystic mature teratoma provoking autoimmune encephalitis. Then, generally, other indications that we can consider ultrasound during the surgery. The first, to define the exact place where to start the incision on the uterus in case of vacuum or in case of intramural fibroids that we cannot see. Then to identify ureters, vessels, other structures in the case of very deep, very severe adhesions. To identify small endometriotic or retroperitoneal lesions. To identify lost IDU, etc. And for hysteroscopy, we will present on Wednesday our research until 2023. Really, ultrasound plus hysteroscopy provide us complete information about the cavity, about the lesion, about the instruments and moving on the instruments, but also about the myometrium, serosa, and surrounding structures. And we find that currently the quality of the evidence is low because all studies, observational studies that we identified, that we have in the moment, but the currently available evidence directly indicates that the use of ultrasound during the hysteroscopy reduces the risk of perforation, for myomectomy, for metroplasty, for adhesions, and also increases the chance of complete resection. And in the postoperative phase, if you're a friend of ultrasound, and if ultrasound is your friend, you don't need to wait radiologists to come or other colleagues to come to diagnose complications such as hydronephrosis or abscess or hemoperitoneum or hematoma. And of course, in postoperative phase, we use ultrasound for follow-up, and it's important for timely recognition of the relapses. So I think that surgeon sonographers can do something that others cannot or can do, but in less effective and safe way for the patient. So thanks once again to Canon for promoting this concept. We, within the Sonomics project, are going to invest a lot in a training, but just in this last diapositive, let me summarize why in each of the phases the ultrasound is important. So in the first, in preoperative phase, okay, to establish the diagnosis, to plan the management, to determine the need for surgery, to determine the surgical route, and to choose the most appropriate thing. Then during the surgery, it is associated with reduced risk of complications, and it increases the chance of complete surgery. And finally, in postoperative phase, we can use for follow-up or for timely recognition of the complications. So thank you very much.